Hey, good afternoon, everyone. Welcome to the third webinar of our four-part webinar series on dementia across the spectrum, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Karen Chan. I'm a care of the elderly physician and an associate professor in the Department of Family Medicine at the University of Alberta. The Office of Lifelong Learning and PLP are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing the best clinical care for patients. I'd like to give the land acknowledgement at this time. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nihio, Cree, and Niitsitapi, Blackfoot, Métis, Nakota, Stony Nakota, Dene, Haudenosaunee, and Anishinaabe lands that are now known as part of the Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. I'd like to give you guys some housekeeping information at this time, and please use the chat feature if you have a question about technical difficulties or about the L3PLP programs and services. If you have a question for the speaker, please do use the Q&A feature of the webinar and review what has been asked already, and you can upvote those questions that you'd like answered more, that you like more. We can't guarantee that the panelists will be able to respond to all your questions, but certainly I'll try to moderate the most popular ones to be answered. A recording of the webinar will be sent via email to all those who are registered. And participants can claim CME credits and complete personal development activity using the My L3 Plan tool. For more information, you can visit the QR code that you see on the screen right here. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. Main Pro participants may also earn additional certified credits by completing a linking learning exercise. So today, I'm so pleased to welcome our two speakers today, Dr. Diana Rucker and Dr. Joyce Lee, who will be providing an overview of the different types of dementia. Diana Rucker is a clinical associate professor at the Department of Medicine here at the U of A, and she completed her medical degree at the University of Calgary in 2004. She subsequently completed training in internal medicine and a fellowship in general internal medicine at the University of Alberta, followed by a fellowship in geriatric medicine at Harvard. Her academic interests focus on decision-making capacity, particularly its impact on hospitalization and cognitive outcomes among socially vulnerable populations, including individuals experiencing homelessness. Joyce Lee is a co-director of the Parkinson's Foundation Center of Excellence and lead of the Geriatric Parkinson's Assessment Program. Dr. Lee completed her degrees in pharmacy and Doctor of Medicine at the University of Toronto and care of the Elderly Fellowship at McGill University. She trained in comprehensive Parkinson's care under Dr. Janice Miyazaki at the Movement Disorders Program at Toronto Western Hospital. Dr. Lee founded and led the first geriatric Parkinson's program in Canada in Toronto, and in 2022, she joined the Parkinson's and Movement Disorders Program at the University of Alberta. To start the Geriatric Parkinson's Assessment Program. Using an approachable and practical format, she has taught many colleagues in primary care, geriatrics, internal medicine, and beyond nationally on high-quality, evidence-based Parkinson's care. Her research interests include innovative care delivery options, patient and caregiver support, and medical education. Thank you very much for your time, and I welcome everyone else here to our webinar as well.
Thank you, Karen.
Hello, everybody. I'm excited for the talk this weekend and to present with my colleague Joyce. Oops. So we're on number 3 today, and we're going to talk about all the other dementias because before we were really sort of focusing more on Alzheimer's dementia and mixed dementia. These are our disclosures. I just have done a little bit of work with the ESI Advisory Board, and Joyce has had many grants and speakers honoraria, as you can see. So today I just wanted to give you some of the short terms. There's VAD, vascular dementia, FTD is frontotemporal, behavioral variant, frontotemporal, semantic dementia, SD, PNFA is progressive non-fluent aphasia. And then we have the PSP, which is progressive supranuclear palsy, corticobasal degeneration, CBD. And then in the synucleopathies, we have DLB, which is dementia with Lewy bodies. And from that, we have PDD, dementia, Parkinson's disease, dementia, and multiple system atrophy. And we'll try to use some of those short forms again as we go along. So the way I always explain to people that, people go, well, what do you mean I have dementia? Or like my loved one has dementia. Is it Alzheimer? Like, is that the same thing as Alzheimer's? So I'm a big lover of the umbrella analogy, and I always explain like are kind of like an umbrella. And the different types would be Alzheimer's dementia, vascular type, Lewy body, and frontotemporal. And of course, there's many other ones like alcohol-related dementia is common, Huntington's disease, HIV, which we actually call hand now, CJD, posterior cortical atrophy, and then chronic traumatic encephalopathy. You can see Alzheimer's is still the most common, 40 to 70%, and vascular is 15 to 25%. Lewy body is sort of similar, 20%-ish, and then the frontotemporal dementias are a little bit more rare. So let's talk about vascular dementia. One way that has really helped me to think of it, or for you, may be that it's really this very teeny tiny vessel injury in the brain. It can also be larger if you have a stroke, but it's injury to the brain, right? And it's not so much a disease like Alzheimer's disease, but it's this injury to the brain, and it often unmasks neurodegenerative processes. It's the second most common type of dementia after Alzheimer, and actually it often coexists with it. And so I call it often mixed dementia. It affects memory, reasoning, or executive function, and it typically follows a stroke, or you can have these series of small vessel injuries from uncontrolled hypertension, diabetes, high cholesterol, atrial fibrillation, and obstructive sleep apnea, because we know they kind of go hand in hand. One causes the other, and of course, smoking. So you may have also heard something called vascular Parkinsonism, which often presents with vascular dementia. And one of the key symptoms is that you will see early symmetric lower extremity Parkinsonism. And this is called gait apraxia. And it typically lacks non-motor symptoms of Parkinson's disease, so other things like anosmia, constipation, REM sleep disorder. And we'll talk a little bit more about Parkinson's disease towards the end or after, in the latter half of this talk. And vascular Parkinson's does not often respond to levodopa. Now, when you image vascular disease, there is a recent paper one of our fellows presented, and it's really the gold standard is MRI. And MRI is wonderful, but you can see it, see the white things. You can see all the little white patches on MRI. But if you look in here, you can also see black patches. And the reason I say this is because I don't want you to start ordering everybody's head to an MRI, because I think the radiologist will be quite upset. The radiologist will often note, they'll say like mild, moderate, or severe small vessel ischemic changes noted on the imaging report. So the treatment is really optimizing the risk factors, and that includes blood pressure, diabetes, like your diabetes. We know lipids, we're treating lipids again more aggressively now, even in the elderly, smoking, and of course, AFib and obstructive sleep apnea. I don't know how you guys do it. It's so hard to have patients be compliant because of the mask. We often recommend SSRI if there's depression. Aspirin isn't really indicated unless we have like officially a TIA or it's secondary stroke prevention or post PCI for the heart issues. Physio, OT, exercise, social connection, and we recommend the MIND diet, which is of course the low salt Mediterranean diet. So I have a case. You see Mrs. D, she's 55, she's young, and she's really worried about getting dementia because her mom, who is 89, has gotten dementia after she has had a stroke. You order a lipid profile, A1C, B12, you measure her BP. And this was actually, I made this question because somebody else asked me, like, would I guess a physician on LinkedIn profile or something like that recommended that we do all these lab tests. So, what other lab tests would you order to prevent vascular dementia? Homocysteine, apolipoprotein B, CRP, ApoE4 genotyping, or maybe just B, if indicated. Which one would you do? I guess that's the same as B. Okay, and do we have all our answers? Okay, yes. So I'm glad to hear that most people would go for apolipoprotein B or maybe if indicated. So I think you guys probably know this better, but basically just order your lipid profile. And if you can treat it, then treat it. But if it's not, if it kind of doesn't look like, it's relatively low or they're right on the cusp, I think that's when I would order the apolipoprotein B, but you can certainly order it sooner. The homocysteine, you don't have to order it. I would just order your B12 and treat if possible. The CRP is so controversial, and I hate as a resident, we used to joke around that if you stepped on someone's foot, they'll have an elevated CRP. So I wouldn't, to me, the CRP is just a hunting expedition, and we use it in the hospital often just to monitor like really chronic inflammatory issues. The ApoE4 genotyping, I have a whole slide on this at the very end. I know a lot of people are really keen, but the thing is, even if you're like have the double gene, like the homozygous, it doesn't necessarily mean that you will for sure develop dementia. You're just at a higher risk. If you have one allele, then your risk is like lower. And if you have no allele, you still might develop dementia. So we can talk about that again at the end. If somebody really wants it, we're starting to do this one for the monoclonal antibodies, but I have never measured an ApoE4. Okay, so let's move on to the very rare, but don't miss it, the frontotemporal dementias. If you suspect FTD, the investigations are MRI, blood work, and refer to neuropsych testing. Early on, someone said, well, when do I do it? And I would say this is a decision when you would refer to neuropsych. They often, you might not catch them on a regular COG screen. And I put a little eye roll emoji in there because there are very special behavioral battery inventories, like the frontal behavioral inventory, the Mittelheim frontality score, the frontal systems behavior scale. I've used one or two of these, and they basically, you're getting information from the collateral, which is going to help you a lot. You refer to Ask Geriatrics, and really what you want to do is get ready because these guys deteriorate fast. So you want to refer to home care, OT, PT, social work, and really stress the importance of future planning. It's young onset in their 50s. Behavior or language is one of your first symptoms. They'll have a family history in 40%. So you can, I got these are your classic Netter pictures. I love this one this man sitting there, decreased concern and empathy for others. It sort of looks like your standard marriage. Um, I shouldn't joke about that, but oral fixation, like we call this Kluver-Bufer syndrome, where they have this fixation and they eat a lot more. It can also be increased sexual interest. And a lot of them have decreased speech and they're just loss of awareness of their personal hygiene. Identifying them matters because their prognosis is shorter. There's a lot of caregiver stress, and you do not want to start them on Aricept, like cholinesterase inhibitors can make it worse, memantine as well, and that you do want to try maybe an SSRI or trazodone. Another way to think of frontotemporal dementia is there's behavioral variant and then also the language variants. Now, the behaviors are like the key features are changes in personality, disinhibition, apathy, inertia, loss of empathy, perseverative, compulsive behaviors, and of course, they have the executive dysfunction. The behaviors, they also develop, the language variants also develop behavioral symptoms with time. So the semantic dementia is almost a way of thinking about receptive aphasia. So these guys are very fluent, but their speech is almost empty. They don't really understand like the meanings of words, and they have a poor understanding of the words. The non-fluent progressive aphasias, they're often, it's very effortful speech, and with time, they often become mute, and they struggle more with getting the language out, and they have agrammatism and difficulty with sentence formation. Now, you might think, well, it gets really tricky sometimes because there's so much overlap with all the dementias. And so this chart is a little bit helpful to think of the earliest symptoms in FTD is really behavior is more of a problem than the cognition. They're inappropriate, they lack empathy, they're often younger. And in the imaging, you'll get this frontal or anterior temporal atrophy. In Alzheimer's dementia, almost the key that you always see is this very early episodic memory loss. And a lot of people will call that short-term memory. And that's okay, like for, the average person. But in academic, it's actually classified as part of your long-term memory. But it is short-term in the sense that if they let go of it, they'll ask it again, even within minutes. Now, the vascular dementia, the key things are early gait changes, and they often have the risk factors, hypertension, diabetes, AFib, stroke, vascular disease. So if I see this on history and they present to me like an Alzheimer's dementia, it's nice if I have a CT, but I can almost bet, and I will often just classify it a mixed dementia. And on CT, you see this like infarcts, lacunae, white matter disease. So this is our case too. We have a 57-year-old male. He sells off his belongings. He can't keep a job. This actually was one of my first cases. He's indifferent to, and if I just go back, this was his CT. Now, this was back before Connect Care, and someone had ordered an MRI, and I was so excited. It ended up being an MRI of the thyroid, so I never did get a MRI on him, but this was his CT. And when his history, he was so strange. He was this really highly accomplished man, but he was indifferent to his family for 2 years. And then he joins a cult. He was like a musician and like had like 6 guitars. He sold them all. And then he even like drove across the country without renewing his license and getting insurance for his car. There was no gate changes. He looks well, but he's kind of disheveled and he has poor hygiene. He had a lot of like automatisms with his language, like he would click and not really pay attention. He scored very well on the MOCA. He just lost 1 on recall, 3 on executive. They did do an exit test, which tests like executive function, and he had a lot of difficulty with planning. Apart from smoking, he's got no vascular risk factor, and an uncle died from dementia in his 60s. What is the most likely diagnosis? We've got Alzheimer's, vascular dementia, behavioral variant, FTD, or semantic dementia. And we'll have the MCQ. Okay, let's see what the answers are. Yes, you guys got it right. Great. So we're going to go on, and my colleague Joyce is going to take over from here.
So then next we're going to talk about gait and motor symptoms and the intersection between dementia and Parkinsonism. So first I'd like to just define what is Parkinsonism. Parkinsonism, the hallmark feature is bradykinesia, and in particular is the kind of slowness that is progressive reduction in amplitude or speed upon repetitive movement. So that is the sort of Parkinsonian type of bradykinesia, as opposed to people just slow because they are having arthritis or other issues. All right. And so the hallmark is slowness plus resting tremor, usually asymmetric, and or muscular rigidity. So that is what we define as Parkinsonism. Of course, now Parkinsonism, not all Parkinsonisms is Parkinson's disease, right? So that's one of the things I always talk about. When we were in medical school, we got taught the trap symptoms. I'm sure you all remember that. But in actual fact, gait issues and postural balance usually come later in classic Parkinson's disease. If the gait issues and postural balance are very early on, then we need to think about the atypical syndromes. When we talk about atypical Parkinsonism, and we're going to talk about some of these today because 3 of these are associated with dementia. And these you may know these as Parkinson's plus disorders. And why were they called Parkinson's plus? Well, actually, it's not because they're better than Parkinson's. It's because they have Parkinsonism plus other features. So in a sense, they are kind of like Parkinson's minus because they actually carry with them a way worse prognosis. So these are the entities known as progressive supranuclear palsy, cortical basal degeneration or cortical basal syndrome, multiple systems atrophy, and dementia with Lewy bodies. Next slide. When we look at diagnostic criteria, there's a huge list of red flags. But when I teach this, I want to give you just the very practical things that you can apply in your daily clinical practice. Essentially, you need to consider atypical Parkinsonian syndromes when people present with Parkinsonism and early recurrent falls, or a rapid progression of gait impairment to the degree that they need a walker by 3 years or a wheelchair by 5. If they have early severe autonomic failure, cerebellar findings or stridor, that may, mean that they have MSA. If they have any kind of eye movement abnormalities, usually you do not get from, normal eye movements to a complete gaze palsy where they cannot move their eyes. There's, of course, a progression, right? So when you check their eye movement, you will often see that it is just a bit slow and it is hard for them to move their eyes downwards. That vertical gaze is a bit impaired. And when they move their eyes from up to down, you might see a little square wave jerk. It's not smooth. So that is a bit of a warning sign that this person may have PSP. The development of early cognitive issues and visual hallucinations, either spontaneously or with low-dose levodopa, is pretty much diagnostic of dementia with Lewy bodies. Okay, next slide. So we're going to go through case 3. A 78-year-old man who is a lifelong smoker with a history of hypertension, type 2 diabetes, presents with gait and cognitive complaints. He's able to use his hands to eat and write with absolutely no issues, but just can't walk properly anymore. A lot of freezing of gait where his feet are stuck, and has had some poor balance with falls. His son had to take over his financial management because he got confused about the bills and he's not able to use the computer properly anymore. No history of REM sleep disorder, anosmia, or hallucinations. His MoCA is 18/30, losing points in executive function, abstraction, and recall, but his recall improved with cueing. So what are your main differential diagnoses at this point? Okay, so most of you chose vascular dementia or atypical Parkinsonism, and that is correct. This is not Parkinson's disease with MCI because this patient is unlikely to have Parkinson's disease because he has absolutely no upper extremity symptoms. This is only primarily lower extremity, all right? And he has no non-motor symptoms that are suggestive of Parkinson's disease. including REM sleep disorder and nausea. And his MoCA is 18 already. And usually when people's cognition is already, you know, I mean, 18 is sort of is mild dementia territory usually. At this point, usually if he has dementia with Lewy bodies, for instance, then he should have more symptoms. He should have REM sleep disorder. He should have maybe subtle hallucinations at this point. And, you know, this is, you know, on paper, this is most likely vascular dementia. However, I put the atypical Parkinsonism there because sometimes these patients end up with atypical Parkinsonism. And we need to recognize that sometimes at the beginning of their presentation, the diagnostic accuracy is not that great, all right, even with the best specialists. And over time, we just need to see how they respond to medication and how they evolve. Next slide. So if you suspect atypical Parkinsonism, all right, with any of those red flags that we went through, order an MRI and indicate which syndrome you're suspecting. You need to make a referral to a specialist at this point, because usually, you know, it is not a reasonable expectation, I think, to really confirm diagnosis of this in primary care, for instance. You need to refer to home care, OTPT social worker, SLP for a video fluoroscopy swallowing test, because a lot of these syndromes do carry with them a higher risk of dysphagia. Look for those non-motor symptoms, and we have a cheat sheet at the end for you on non-motor symptoms and how to manage those. And I think one of the most important things with these syndromes is that you need to support the family and patient along the way, and early discussion of GCD because they do have worse prognosis. Next slide. And usually when I talk about atypical syndromes, people's eyes glaze over because it is so difficult, you know, if you don't deal with these on a regular basis to figure out which one is which. But I have a very quick and easy way to distinguish them. All right. So if you group them into tauopathies, which is PSP and corticobasal, versus synucleinopathies, which is dementia with Lewy bodies, Parkinson's disease, and MSA, then it's way easier to distinguish them because you see that the tauopathies do not have REM sleep disorder. They don't generally have visual hallucinations. They have more FTD-like symptoms over time. They don't respond to levodopa very much, all right? Whereas if you're talking about Parkinson's disease or dementia with Lewy bodies, these diseases are defined by a lot of non-motor features. So REM sleep disorder is one of the most important symptoms to inquire about. And the way you ask about REM sleep disorder is you need to ask, you know, if there's a bed partner, that's the best. Then you can ask, you know, this your loved one scream, yell, have vivid dreams, punch or kicked in their sleep? Have they fallen out of bed? Have you moved to a different bed because you've been kicked in your sleep? You know, and REM sleep disorder can actually be present in these conditions for up to 2 decades prior to the onset. Visual hallucinations, of course, is a prominent feature in dementia with Lewy bodies, all right, and Parkinson's disease dementia. And, you know, those are present in the synucleinopathies, but not the PSP or CBD or the tauopathies, because that's just, you know, a very good distinguishing feature. Autonomic dysfunction tends to be way more prominent in dementia with Lewy bodies and Parkinson's disease, and especially in MSA. So MSA, I should mention, as an atypical syndrome of Parkinsonism, it is one of the more common atypical syndromes, but it does not usually carry with it dementia. So I'm not going to go into it a lot this time. We have a separate course that goes through this in more detail. Okay, next slide. So let's just, you know, talk a bit more in detail about PSP. So PSP typically presents with a lot more axial rigidity compared to limb rigidity. And there are different subtypes of PSP that we're not going to go through. But as I said, with the loss of, you know, eye movement, vertical saccades, that is a feature of PSP. But in early stages, you're just going to notice perhaps that the person has a staring expression, or has this hyperactive frontalis muscle, like a surprised expression on their faces, all right? And they, again, typically do not have any of those synucleinopathy type features including REM sleep disorder. Even when they have dementia, when they have trouble with their language and this later stages PSP, they will not have the visual hallucinations that you would expect in the other types of in the synucleinopathies. New slide. So the core features is the oculomotor issues, the vertical gaze palsy, which we talked about. And if a person has eyelid opening apraxia, like they say, my eyes close and I have trouble opening them, that is a common feature in PSP and is a definite red flag. It doesn't usually happen in regular Parkinson's disease. Early prominent postural instability and early falls, a more rapid progression of their gaits and poor levodopa response. These are usually the features of PSP. And when you look at an MRI, you'll see that atrophied midbrain, in the picture in the lower quarter there. It looks kind of like a hummingbird. So there's a way to measure this, which is essentially measuring the ellipse of the pons versus the midbrain. And if the midbrain is less than 50% of the pons, then it's differential midbrain atrophy, and it is diagnostic of PSP. And so with PSP, the kind of dementia that develops again is more an FTD kind of picture. So we need to treat them with SSRI or trazodone for the FTD symptoms. But generally, they don't respond very well to cholinesterase inhibitors or memantine. Those tend to actually make them more agitated. The allied health professionals are very, very helpful because these patients present with a lot of falls, behavioral difficulties, functional decline, dysphagia, and dysarthria. Okay, next slide. So cortical basal degeneration is actually one of the more rare kinds of atypical Parkinsonism. It usually presents with marked hemi-Parkinsonism and kind of this like severe rigidity on one side. And the typical history that you might get is that someone is, right-handed and they cannot use that hand anymore because it simply doesn't do what they want it to do. So there's a significant apraxia component to this, and they often have to switch to the other hand. When you examine them, you'll see they usually hold that side in a flexed kind of position. Sometimes it could be dystonic posturing as well. And when you ask them to do things with that hand, they have lost function. So they're completely apraxic. If you test for their cortical sensation, like rhaphisthesia and so forth, they would have lost that. And yet, on the brain imaging, you would see that there's no stroke. So oftentimes, these patients get misdiagnosed as a stroke. And I can't tell you how many times I have come across patients when they're admitted to hospital with falls, and they were like, oh, I was told I had a stroke. No, they don't have a stroke. They have cortical basal. And when you order brain imaging for these patients, look carefully to see if there is differential asymmetric atrophy. This is almost never reported in the radiology reports. Like I have never seen it reported. So if you notice your patient has right-sided apraxia and right-sided severe hemi-Parkinsonism, right? Look for the left-sided atrophy. And you might be able to diagnose this yourself because it actually is quite obvious when you look for it. And these patients present with quite a bit of dementia, all right, with frontal features, often with behavioral issues, impulsivity is a big feature, and language impairment. Next slide. So case 4, 78-year-old man presents to your clinic. He has had increasing difficulty using his dominant hand, which is his left hand, over the past 18 months. He started using a walker as his left foot often got stuck while walking and he would lose his balance. His family reports that there has been some personality changes. He's more withdrawn, irritable, he's craving sweets. His family had to take over driving, banking, and medications, and he was not managing these things safely anymore. He has not had any hallucinations, vivid dreams, or loss of smell. On exam, you notice that his left upper extremity is quite stiff and held in that flexed position. and there's no lateralizing weakness. And here is the imaging. What is his most likely diagnosis? Excellent. You got it. Okay, he has not had a stroke. All right, there's no stroke on there. But you can see that differential atrophy. If you look at the right side, there's much more space. The sulci are larger, right? It is, the brain parenchyma is quite a bit more atrophied. So again, this kind of imaging, often gets reported as mild atrophy consistent with aging, and they don't usually mention that differential atrophy. Sometimes, if you specifically ask if the patient seems to have asymmetric atrophy because they may have corticobasal, then the radiologist may look more carefully and report it. But generally, if you don't do that, it's never reported. Next slide. Next, we're going to talk about dementia with Lewy bodies. Essentially, this is dementia, which is just cognitive decline in one or more domains that is affecting function, plus one or more of these features. Spontaneous Parkinsonism, that means, not drug-induced. Visual hallucinations, which may be exacerbated by medications. These tend to be well-formed and complex. Fluctuations in their cognition or attention, or REM sleep disorder. And as I mentioned, REM sleep disorder is an extremely helpful feature to ask about. Don't miss it. A lot of people misdiagnosing dementia with Lewy bodies because they did not ask about REM sleep disorder, and they may not have examined for subtle features of Parkinsonism. Because as you can imagine, that fluctuations in cognition or attention can be difficult to tell, right, on history and even on exam. And some patients may not have early visual hallucinations. All they may have is, let's say, dementia, and they have REM sleep disorder. That's one feature. That's already possible dementia with Lewy bodies. If they have, let's say, REM sleep disorder and a touch of spontaneous Parkinsonism, they already have two features, and that's probable DLB. So don't miss this diagnosis. Next slide. I want to also, point out that DLB, which is dementia with Lewy bodies, and Parkinson's disease dementia are actually on a spectrum. And together, they constitute what we refer to as Lewy body dementia. And the diagnostic criteria that you may be familiar with is if the dementia and the Parkinsonism present within 1 year of each other, then we call this dementia with Lewy bodies. If a person has been diagnosed with Parkinsonism and then a few years later, or Parkinson's disease, and a few years later, 3 to 5 years or more later, then they develop dementia. We tend to call that Parkinson's disease dementia. But in actual fact, there are many patients that fall somewhere along the spectrum. I've had many patients that have, Parkinsonism, they respond to levodopa, so, technically they're Parkinson's disease probably. They don't have dementia at the beginning, but within 2-3 years, they start having dementia and significant visual hallucinations. So in my mind, these people are kind of in the middle of the spectrum. So this is, we like to put people in boxes, but in reality, they exist on a spectrum. And just remember that these patients also tend to have a lot of, other than, the Parkinsonism, REM sleep disorder, visual hallucinations, etc., they also tend to have a lot of autonomic dysfunction. So orthostatic hypotension, constipation, bladder issues, those are prominent as well. Next slide. So case 5. 72-year-old retired lawyer presents with her husband. They're worried about her cognition. She has declined in her ability to use the computer and make big family dinners. He has had to help her with her bills and emails recently. Now, this is obviously not normal for, someone who is quite functional and a retired lawyer. She has vivid dreams. Her husband says that she has been yelling and kicking him in her sleep over the past 10 years. On exam, she has a bit of a bilateral hand tremor and she looks slightly frail. What is her most likely diagnosis? Awesome, you got it. It is not Parkinson's disease dementia. Oh, a quarter if you thought it was PDD. Well, this is someone that's presenting with cognitive impairment, subtle Parkinsonism, and has had REM sleep disorder. So this is the dementia presentation, and therefore this is dementia with Lewy bodies. And not like she's had Parkinson's disease and you've treated her with levodopa for some time, and then she develops dementia, in which case that would be Parkinson's disease dementia. Next slide. So PDD, all right, is a whole other topic, but essentially someone who has had Parkinson's disease, usually for a while, by 4 or 5 years after diagnosis, typically 50% of them would have dementia. By year 8 to 10, up to 80% would have cognitive issues. So again, these things exist on a spectrum. So when you've had a patient with Parkinson's disease and they're on a whole slew of medications, including levodopa and tacopone, maybe amantadine, maybe a dopamine agonist, etc., and they come in and they have psychosis. They may have hallucinations, they may have paranoid delusions, etc. You always have to, assess for the development of dementia. Don't just put it off to, oh, well, this is PD psychosis is because of the medications. All right. Yes, the medications can be contributory, but when people have had Parkinson's disease for a number of years, Parkinson's disease dementia is common. All right. And there's medication for it, particularly donepezil, rivastigmine are class 1A recommendations. And the alternative is memantine. Next slide. So PDD and DLB both have more cholinergic deficit than Alzheimer's disease, and therefore they get much more benefit with cholinesterase inhibitors, including donepezil and rivastigmine compared to Alzheimer's disease. I have had patients with dementia with Lewy bodies, and they start off with a MoCA of 20, and they go up to 26 when I put them on donepezil. That degree of improvement is basically also diagnostic of DLB because nothing else improves that much. In AD, vascular, anything else, nothing's going to improve that much. All right. So this is, DLB and PDD are diseases that are very treatable, and it's important to not miss them. First line, donepezil or rivastigmine. Second line, galantamine, because the studies are, there are fewer sort of studies on that. But galantamine can be tried if people don't tolerate donepezil or rivastigmine. Memantine can also be used if they don't tolerate or there are contraindications to cholinesterase inhibitors. So one point about the use of cholinesterase inhibitors is that in this population in particular, you have to watch out for the development of orthostatic hypotension as a side effect. Orthostatic hypotension does not develop pretty much in any other population when you treat them with cholinesterase inhibitors. And of course, there's the usual GI side effects, about 10%, nausea, vomiting, diarrhea. These patients may also have a bit of increased tremor and Parkinsonism in some cases, and of course, the weight loss. And then the cardiac side effects, which is bradycardia, which is why left bundle branch block is a definite contraindication. Any heart block beyond first degree, anything more than bifasicular block. If someone has severe orthostatic hypotension, I don't start them on a cholinesterase inhibitor because that's just asking for trouble, at least until I completely stabilize them from that perspective. Next slide. So practical tips is that, if you have no contraindications, the first thing you can use is donepezil 5 milligrams daily with breakfast. That's easy peasy. I like using it over rivastigmine because rivastigmine is twice a day, and that is just more difficult for patients to manage. And also, when you start people on donepezil 5 milligrams, that is therapeutic dose already, whereas rivastigmine at 1.5 milligrams BID, that is not therapeutic, right? 3 milligrams BID is the lowest therapeutic dose. And in order to get people to have Blue Cross coverage for these medications, you need to fill out the Alberta Blue Cross access form. You have to put AD on the form. You didn't hear that from me, but that is true. You can't put DLB because they won't cover it. all right? And they'll need a cognitive assessment. If your patient, if you know that they have DLB, they won't do a cognitive assessment, you can do an inter-RAI, which is based on function. Don't stop cholinesterase inhibitors suddenly because there's a withdrawal effect. It can precipitate delirium. If they have side effects, unless they have like a really sudden bad side effect like left bundle branch block, in which case you have no choice but to stop it. In general, tapering it would be better than stopping it suddenly. Memantine is quite a reasonable alternative. Based on my clinical experience, about 50% of people do derive benefit from it in terms of their attention, sometimes even improving their gait freezing because of the improvement in attention, and certainly often helpful in the psychosis. And then also manage the non-motor symptoms, which we're going to talk about next. New slide. So again, with psychosis and DLB PDD, you always use cholinesterase inhibitor first if no contraindications. Try and remove culprit meds. Whenever you think of needing to use quetiapine, for calming someone down or for their psychosis, always kind of think about, are they on the cognitive enhancer first? Either cholinesterase inhibitor or memantine, because we don't really want to overuse antipsychotics because they really do carry with them a lot of side effects, including constipation, orthostatic hypotension, more falls, etc. And I also want to note that only quetiapine and clozapine are okay to use as antipsychotics. Any other antipsychotics are contraindicated in Parkinson's disease and dementia with Lewy bodies. If people are noting that they have nighttime hallucinations, especially sleep-related, like hypnopompic hallucinations when they're waking up, that's a spectrum of REM sleep disorder. And so you use melatonin long-acting over quetiapine. All right, next slide. In terms of for patients with Parkinson's disease, because over time, oftentimes you see people with a whole slew and regimen of medications from their neurologist. And when they get psychotic, we always have to kind of rebalance the priorities. You need to almost prioritize the non-motor symptoms more than the motor symptoms at this point. If their psychosis and impulsivity are causing more falls and just making their life, lowering their overall function. So whenever someone presents with psychosis with Parkinson's disease, you have to do a medical and cognitive assessment. And sometimes you do need to reduce some of their dopaminergic and their Parkinson's regimen. And the little chart on the right tells you the order in which to do it. Next slide. So now we move to the low-hanging fruit of Parkinson's disease. And these are also applicable for DLB in general. So the 3Ds are dementia/psychosis, disordered sleep, REM sleep disorder, and depression/anxiety. And those are some of the tips, what you check for and what to do for these things. The next slide. 3Bs are bowels, bladder, blood pressure, and bone health and falls. And these are the things that we go through in detail in the comprehensive Parkinson's course, but I just want to include those here for you so that you'll have access to that. So lastly, I just want to tell you that, in terms of the distinguishing the different features of different types of Parkinsonism and deciding what they are. So if you identify Parkinsonism, if there's a ton of lower extremity symptoms and nothing on the upper extremity, all right, if they're able to write, crochet, do whatever with their hands, but they can't walk, and there's vascular disease on imaging, most likely it's vascular Parkinsonism. If they're on dopamine blocking drugs, anti-epileptics, lithium, and you remove those drugs and they get better, that's drug-induced Parkinsonism usually. And if it's not those, then you need to consider, are there any red flags that we went through, like early dementia, falls, autonomic dysfunction, etc. If yes, then you need to do an MRI, refer to specialist, and then according to the symptoms, if there's no REM sleep disorder, and there's no autonomic dysfunction, etc., there's more sort of frontal features, most likely that's PSP, CBD. If you have REM sleep disorder and you have autonomic dysfunction, it's probably going down the route of dementia with Lewy bodies versus MSA. And if they don't have any red flags and they have asymmetric rest tremor, and they have some non-motor features like REM sleep disorder, anosmia, And if you try levodopa, they have significant benefits in their motor symptoms, then that's Parkinson's disease. So that's kind of a whirlwind tour of dementia and Parkinsonism, which is quite a complex topic. We have a comprehensive Parkinson's care course, which is coming in fall 2026, so stay tuned.
Okay, and thank you for that, Joyce. Just a few questions from last week. The driving assessment in Calgary, I put it here. People also said it's not up to us to take away the license. And I said, correct, the Ministry of Transportation sends the notice, but you have to give a letter that you're sending to the MOT to the patient. And then what labs would you recommend? Would you recommend not to diagnose, but to check for deficiencies? And basically, I don't do a lot of labs even in my clinic. If I had to recommend, it'd be B12 TSH lipids, A1C, control your blood pressure. I would put everyone on vitamin D3, 2,000, no more than 4,000. And somebody said home care is a struggle. Who assesses the maximum care? Actually, home care does that assessment. And I spoke with Denise, one of our panelists here. I said they can get up to 38 hours. If they live by themselves, they obviously are going to qualify for a lot more hours. And if they have a caregiver, they may not get as much. You can always ask home care to refer to a day program is a good way to get them to have socialization. And someone asked me about like Imovane. I'm trying to reduce it. Can I do a cross taper? Do I have to do washing out? Joyce is a pharmacist, so I personally don't even do washouts. I just cross taper all the time. And I've actually in the
I
last,
like that actually.
yeah, in the last,
Yeah.
like you like washouts or cross
No,
taper?
I like cross taper because if
Yeah,
someone is struggling with depression, anxiety, or sleep problems, if you completely wash them out, then they're going to have like severe symptoms.
yeah, exactly. And also I wanted just to say, yes, I don't like people on Imovane. Like if they're on 21 milligrams or even 15, yes, try to decrease. But I've gotten less rigid in my last, I'm becoming soft in the last 5 years. Like sometimes all you can do, and it makes it more easier for the patient to accept, is to just try to decrease. And then if they're so hung up on it, it's just not worth like getting too hung up about it if that's the only thing that works for them. And just about ApoE, I made this quick presentation. So this is the first numbers are what you get in the percentage of population. This is of course white Caucasian in Europe. And then the second after the three dots is your lifetime risk if you're in that. So if you have no ApoE, you have a lifetime risk of 10 to 15% of getting dementia. Of course, it increases with time. If you're heterozygous, it's the same. It's like about 20 to 30%. You also have a 20 to 30% of the people have that heterozygous. And if you're homozygous, very few people, like 2 to 3%, and your risk is about 50 to 70%. So there's still lots of things you can do. And it really depends, on that person, I guess, to see, do they want to know? I think somebody said like they might want to quit their job earlier. I don't know about that. I be careful how you counsel people. Okay, questions, anybody?
Okay, I see questions on the chat.
Okay.
She'll do it. Karen will handle it.
Yeah,
Okay.
yeah. So thank you so much, Dr. Rucker and Dr. Lee. There are a few questions, although one of them you already answered actually. It was around does memantine help with visual hallucinations? And I
Yes.
think I heard it there that it's 50% basically. One of the questions was actually kind of back to a little bit of the basics of what are Lewy bodies at the end of the day?
Okay. So Lewy bodies are basically clumps of alpha-synuclein that is misfolded. So within our brains, we have all these different proteins. And as we know, basically a lot of the dementias are basically misfolded proteins, right? And so in particular, like Lewy bodies are just like little inclusion bodies of alpha-synuclein. And so these Lewy bodies in DLB, in Parkinson's disease, basically they are not just confined to the brain. So for Parkinson's, for instance, the Lewy bodies are more confined to the basal ganglia and less so in the other areas of the brain. All right. In dementia Lewy bodies, There are some in the basal ganglia, and they're also spread throughout the cortex, which is what gives rise to the cognitive symptoms, right? And then when the Lewy bodies are spread throughout the peripheral nervous system, the autonomic nervous system, that is what gives rise to those autonomic features, the non-motor features, the 3Ds and the 3Bs that we talked about. So basically, like, what symptoms you get depends on where these Lewy bodies are.
And next question is, how do you taper off of donepezil?
So typically,
Oh,
if
yeah,
someone's on 10, right, 10 milligrams daily, then you go down to 5 milligrams daily. You kind of taper them down as you would kind of ramp them up. A lot of my patients with dementia Lewy bodies or Parkinson's disease dementia, don't they often don't tolerate higher doses. So I usually leave them on 5 milligrams because that
yeah,
usually is sufficient.
and generally the Canadian guidelines, Karen can join in as well as she's a geriatrician. I don't, there's been very small, poor studies showing that if you take someone off, just because you think, oh, I want to decrease the pill burden, that you can actually like provoke a drop in cognition. So right now, the general guidelines say don't stop the drug unless they're like really end stage, like they're bedbound
Yeah.
and mute. Having said that, like if they have like, if they end up in CCU and have a really bad like heart block,
Left bundle branch
or like
block, then you
they have
have like no
very vivid
choice.
nightmares, or they just have really bad weight loss, then that's an indication. And I haven't, you're always weighing the risks versus the benefits, is kind of what I say. But especially in the Lewy body and PD population, that is
Don't stop it.
that's the last drug you want to drop and
Yeah.
stop.
Just don't stop it because you can precipitate a delirium for sure.
Next, any
Yeah.
questions?
Yeah, there's one more question here. What would the knowledge of apolipoprotein B data do to change your approach to a patient? What cutoffs do you use to change treatment?
For the lipids, that is that
Yeah,
right?
that's right.
Apolipoprotein B, yeah.
Yeah,
Mhm.
I would just I'm not as well versed in it. That's like more I would say if it helps, if it qualifies them, that it would lower their lipids, I would just start them on a statin. Um, if they're sort of right on the edge, it's just to start them on statin therapy. Karen, any do you do it much or
No, I don't. I mean, I oftentimes don't test for apolipoprotein B because it's usually kind of in many ways black or white for me, whether or not they have the risk factors that warrant a statin.
Mhm. Any other
And
questions?
that's all the questions on there, but we still have a couple minutes from what I can see. Um, Thanks so much. That was a really great presentation, a whirlwind of many different diagnoses.
Thank you, everybody.
Thank you. Hope to see you at the course.
Okay, bye.
Bye.
Thank you.
Thanks a million, folks. That was awesome.
You're welcome, Denise.
Yeah, and a little shout out. Raj Padwal did a great session on October 9th on Beyond Statins, lipid management that lasts. So all the recordings are there, folks. If you want to know all about apolipoprotein B, check out Raj's talk.
Great.